There's over 25 million Americans that do not have access to broadband internet. So when you're doing your needs assessment for ways patients like to learn, it's also important to do, a digital needs assessment. Do you have a smartphone? Do you know how to use your smartphone? Do you have a computer? Do you have internet? Things like that will really help to know what type of information you can give to patients. Don't assume people can read. Don't assume people can write. Don't assume if someone speaks Spanish that they can read Spanish. You may have a resource within your institution that you don't know about. Especially if you work at a larger institution, there are many times where people will reach out to us and say, we need a resource or need something on this, and it's already there.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Beau Amaya, Associate Director of Patient Education and Engagement at Memorial Sloan Kettering Cancer Center in New York, New York, to discuss what nurses should consider when delivering patient education assessments at all phases of the treatment plan. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Beau.
Thank you. Thank you for having me.
So I'm interested in learning about your career trajectory and how it led you to your current role as Associate Director of Patient Education and Engagement. Can you share that journey with me?
Yeah, sure. So I actually graduated nursing school with my associate degree in about 2003 and became a travel nurse and came to New York City. Never wanted to work in oncology. That wasn't really my experience, but I started this job at Memorial Sloan and it really connected me with what oncology care is. For a long time, I think when you don't work with oncology patients, there's this sense that cancer care is very doom and gloom and full of a lot of sadness. But when I came to Sloan, I found so much hope and cure and just joy. And it really led me on this path to really become an oncology nurse. So I worked in the inpatient unit for a while. I worked as an outpatient office practice nurse. And then prior to this role here for 5 years, I was actually the nurse leader for an outpatient facility overseeing chemotherapy, infusion, surgical, medical oncology. And in that role, I saw how the effects of patients not really understanding some of the tasks that we were assigning to them or not understanding how to care for themselves. And it really drove me to thinking about health literacy and thinking about patient education. And I recently graduated from Hunter Bellevue School of Nursing in 2020 with my master's degree. And in one of my projects there was talking about chemo education and really looking at how chemo education is performed and how that really affects the way patients, how their optimal healthcare is. So this job, I really wasn't looking for a new role within MSK because I was very happy as a nurse leader in my role. But I saw this job come up from another colleague that told me about it and said, maybe this is something you should do as your next role. So, it's been a blessing. It's really revitalized my sense of what we can do as nurses to really help patients and their caregivers achieve optimal health.
That is a very exciting career path. And it's great to hear you talk about how oncology wasn't something that you ever thought of, but how once you got into it, that love for oncology just really bloomed. And I think that is the way it is for a lot of people who end up in oncology. They never thought they'd ever work in this area, but it really has a way of drawing you in.
Yes, for sure.
As you talked about your career path and the different roles that you've had, I was thinking about even as nurses, we change roles all the time and, we have that education and background and we can also do more training and learning on what those new roles are. And it's difficult, but it's not super difficult for us. But then I think about our patients that we have. And, there's so much that goes into a new diagnosis for a patient with, a diagnosis of cancer. And then, all the discussion about all the treatments that they're going to have and what those look like, all the names of the chemotherapies. And, as well as I do, there are definitely names that we trip over when we say them, let alone, our patients who've never had any kind of experience at all. And all of the, you go into a patient room or an outpatient clinic and see all of those pumps all around everybody. And, just that overwhelming feeling of how do I deal with this from a patient point of view? And then here we come, the nurses who want to make sure that we're educating them and making them as informed as possible during this treatment that they're going to be having. So it's so important for us as nurses to be able to assess a patient and what their educational needs are, and how well they will be able to understand what we're going to be giving them and the materials we'll give them. So let's start this discussion and talk about patient readiness and preparedness. How do nurses start that assessment and, start looking at patients in that view for the education we're going to be providing them?
Yeah, I think that it's important that a learning needs assessment is done upon initial input into the healthcare system, wherever you're working at, to get a sense of where patients are. And I think one thing that is really great to follow is Joint Commission has a lot of standards of what those initial assessments need to be. So, really including patients like cultural and religious beliefs, their barriers, emotional barriers that our cancer patients face, really their desire, motivations to learn, any physical or cognitive limitations they may have, and like barriers to communication. So really doing that from the get-go of upon that initial assessment when you're meeting patients, and then documenting that somewhere that can be seen not only within nurses, but within other disciplines across the hospital. I think that is really important because a lot of time with patient education, I think a lot of us feel, and especially as nurses, that it falls only on the nurse or only on our discipline to do patient education. And it's really everyone's doing patient education. And really, we need to capture those things and make sure our assessments where we're doing these learning needs really gets shared with all other disciplines that we're working with.
So in doing that needs assessment, is that something that we should just do at the beginning of their treatment? And then, we put it in their chart and hope that everybody looks at it and then it's there. Or is that something that needs to be, reassessed along their treatment timeline?
Oh, it definitely needs to be reassessed because one thing about when you look at learning needs assessments, you're looking at these different periods of time. Because one thing that I focused on through my career is almost that permission to give information and talking to patients where you say, are you okay talking about this now? Do you want to learn about this right now? And sometimes patients are not in that mindset, or their caregivers are not in that mindset to learn at that moment, especially with our population of patients. They may get a scan result that they weren't expecting. They may get prolonged chemo, more radiation. So sometimes educating them about their different treatment plans, that's not the right time. So I think it's always important to include that in the conversation as well. And I think things change over time, right? So a patient initially may say, I want everything printed to me and I want everything handed out. And then they learn that, maybe your hospital offers different educational programs, or they offer an interactive module that the patient can get access to. And by us sharing that with them, letting patients know we have all these things that are available, over time, patients may say, oh, I really would enjoy that. Let me go to this online website to figure this out. Or is there something else that I can learn? Is there a video that I can watch? So I think taking in consideration of the different medias or the different modalities of what they can receive in education is important as well. And really, the education needs in the hospital is going to be different than when a patient is coming into an outpatient clinic visit or coming to their, eighth session of chemo instead of, their follow-up care a year later. So definitely those time points really are important when you're delivering and assessing pre and post patient education.
Can you give us some examples of some standardized screening assessments that you've used or that nurses who are listening could access and use with their patients?
When we're using assessment tools, I think it's important that we're looking at what the patients need. So do they need interpreters? Do they need translated materials? Do they have a disability or something that will prevent them from accessing care? Do they have a smartphone? Do they have a computer? These kind of like needs that patients may have. And then when you're documenting these things, those things we can carry on forward as we go through. You can notice, if a patient is primarily Spanish speaking, that's something that can be documented in the medical record. And then that way, that's always within there for everyone to know. And then as time goes on, I think it's important to ask patients using one of the things that is most evidence-based when you're looking at educating patients is using that teach back methodology and really talking about, did the patient really understand what we were trying to tell them? So not just saying to a patient, did you understand what I just said to you? Do you understand what the chemotherapy is? And the patient says, yes, I understand. Most of the time, patients don't understand when we're saying that. So really going back to that, having patients explain to them in their own words, what did you hear me tell you? What did you understand what I said to you? And then that volley back and forth that you can have with the patient really lets the clinician, the nurse really know what the patient's retaining and maybe can discover some barriers there. Because on initial screening at times, we don't capture everything. The patient may not disclose that they can't read. The patient may not say they're having an issue with retaining information initially. So that volley back and forth, you're having this conversation with patients, especially about patient education and their treatment, really get us to discover more things about patients.
You just mentioned barriers. So now that, the nurse has done her assessment, what are some of those barriers to patient education that a nurse might identify? And let's talk a little bit about what they are and how can nurses overcome those barriers?
Yeah, I think one of the biggest barriers that we have with patient education is overall health literacy. So most patients, I would say, I think some of the latest data says about half the people that we're giving education have low health literacy, meaning they're not really understanding really the weight of what's going on. So really looking at things that we can use plain language, make sure that we're giving things to patients that are the readability as well. So health literacy is an overall theme of a barrier. And I think when you look at certain aspects, language can be a barrier. So if you're in we're here in New York City, so we have every kind of language, every kind of culture that we serve within our patient population. And if we don't have a resource that's in a certain language, that's going to cause an issue for the patient because we're not giving them printed information or information that they can read in their language that they prefer. So there is, use of interpreters and translation. And I think sometimes people forget that those are two different disciplines, two different groups that are helping with language assistance. So translators are really looking at the written material. And then interpreters are in that oral when you're talking with a patient. So sometimes we'll have our interpreters read something in English and then interpret it to the patient. And sometimes things get lost in that. So it's important that we're using those right, resources we have when we can. Also using staff as a translator or an interpreter. I think we've all been in those positions where we have a colleague that maybe speaks a native language. And then we say, well, can you translate to this? Can you interpret this for them? And they may not be a certified translator or certified interpreter, and things can get lost there. And then also, relying on family members to interpret medical information is really not the best practice. There's always times when it's useful. Can I get you a cup of water? Is your, family member in pain? is something else going on in the immediacy. But really to have family interpret what is being said can really lead to like poorer outcomes for the patients because they may not be getting the full story because their family might be protecting them. I think we all have done this, right? We've all learned certain things about ourselves or our family, and we say, you know what, let's not bring this up right now. Let's talk about this another time. And really taking the patient away from their right to know what's going on in their healthcare.
Those are some really great points and great ideas for nurses to really think about what the barriers might be and how they might overcome them. So, when we were talking a little bit earlier about the screening, you mentioned the different ways we might educate patients and how we might deliver those educational materials through different types of media. Can you talk a little bit about what some of those options for education for our patients and how we might determine what types might be best for those patients?
I think most traditional is, a printed material and you one-on-one are having discussion with the patient. And that's traditionally how a lot of patient education is done. And then we look at things like, video resources, things that we can give to patients to say, like, if they have access to the internet at home, they can review things at home or they can watch it while they're within the medical facility. But videos that they can watch, also interactive modules where maybe they receive some kind of PowerPoint, or like we use things called like a SABA module at times where it's like interactive. Patients can click on certain things to learn about their treatment plan. And then also virtual programs. So there's programs where patients can get like almost a group teaching. So say a patient is getting scheduled for breast surgery. You can have a session where you have one educator talking about the breast surgery with a group of patients in a virtual space. And this allows for people to share common, stories, share how they may experience things. We've done those ways where it has different modalities that the patients can learn from. When we're talking about different modalities, I think a lot of people think because we're in this digital age that everything's digital, now that patients don't want handouts. That's really not the case. It's really shown that patients prefer a multi-modality way that they can get information. They want the printed as well as the video, as well as the online resources. And there is this lore, and like I feel it too when I've gone to the doctor. Sometimes it feels like if someone hands you a piece of paper, it's almost like that is important. And sometimes when you look stuff up online, that may not be as important. So I definitely have heard patients say that. And then I think we have to do some, you really have to not assume about what patients have. We can't assume that everyone has a computer, everyone has a smartphone or a laptop. A lot of younger people right now, they don't have computers or tablets. They just have their phone. We can't assume that people have access to the internet. I recently went to a webinar about health literacy in the digital age, and there's over 25 million Americans that do not have access to broadband internet. So we have to think about these things as well. And almost when you're doing your needs assessment for ways patients like to learn, it's also important to do, a digital needs assessment. Do you have a smartphone? Do you know how to use your smartphone? Do you have a computer? Do you have internet? Things like that will really help to know what type of information you can give to patients. And then one thing I wanted to add when we were talking about this is a lot of patients are now receiving their information on their mobile phone, right? So a lot of patients have iPhones, Androids, and that's how they're getting their information. They're logging into patient portals, going on the website, checking their lab results. So you really got to make sure if you have education materials in that sphere, that it's mobile ready, that it's mobile friendly to read, that when a patient goes from the website to their mobile phone, that it looks okay. And I think it's really important to really collaborate with your digits and web design colleagues to really make sure all these great materials that we make as nurses really translates to how patients can access that information on that digital end.
Thanks. I think that we do take that for granted. We do take the digital aspect of things for granted and think that surely everybody has that and everybody has, like you said, a smartphone or a computer at home. And, we really do have to be thoughtful when we are doing that assessment and making sure that we don't overlook any of those things that you've mentioned. So one of the other things that you mentioned earlier was the teach back method. And with everything that we do have to teach our patients and, the complexity of what we're doing, you also mentioned health literacy and how patients may not have that. And it's so important for us to use plain language when we are, teaching our patients and talking about medical terminology. So, talk a little bit more about how nurses can implement the teach back method in practice, when they are working with their patients in the medical terminology and things like that.
So it's really important to know that teachback is evidence-based. It's really backed by the research that this is the way to really help patients understand what we're telling them and really teaching everyone, not per se the same, but really going in there and saying, like, I'm just going to do this methodology with everyone, regardless if they are someone that, has told me they can't read and write well, to someone that is practicing as a physician somewhere. You really want to get it to those very basic levels. And I think for nurses that are unfamiliar with the teach-back method, there is a plethora of information out there that is free. It's available. There's really this, if you Google always use teach-back toolkit, it will give you a plethora of information that will really give you the tools on how to do this. Really, the Agency for Healthcare Research and Quality, the AHRQ, they also have a universal health literacy universal precautions kit. And what that is talks about health literacy in general, talks about plain language, talks about teachback, talks about these different tools that people can read. And it's actually not that hard to do. It just takes time. And I think that's one of the biggest barriers. But I think of it as almost an investment, right? So one of the cornerstones of teachback is that you're really trying to explain things in plain language. You're really trying to meet the patient at eye level, like you're having a conversation with them. And you really are, you're teaching about certain aspects in short forms and then say, explain that to me in your own words. And if they don't understand or they're not saying it the right way, no shaming them, no making them feel bad that they don't understand what's going on. You say, okay, you know what? I understand how you could have heard that. Let me explain it again and let me know how it goes this way. And really explain that the reason why you're doing is to help them. So it takes time to do this, but I think of it as like you're investing that time up front. So you're giving the tools so the patient knows how to take care of themselves at home. So if they have a symptom or they're not feeling well or something's going on, their immediate action is not to just call the doctor's office. Maybe they'll use those tools you gave them and they could say, you know what, we talked about this and the nurse told me I can do this, and go back to those reference materials so they can take care of themselves. So I think teachback does take time, but it also really allows patients to be, and their caregivers, to really be able to take care of themselves in a way that maybe they won't have to call the office as much. Not that we don't want our patients to call us and our patients to, know that you can always discuss with your healthcare providers, but 10 o'clock at night on a weekend, we really need to give them the tools so they can help take care of themselves.
So we've talked a lot about the patient and how we can make sure that we're assessing the patient and identifying the right tools to use. But let's talk now about the importance of the caregiver's involvement. How does that kind of play into all of this?
Well, we know our caregivers are crucial in the delivery of care. Most of our patients now are being taken care of at home, and most of the patients being taken care of home are being taken care of by family. So I think it's really important it's almost like you're doing a needs assessment for them as well. Like in that conversation about, how do you like to learn? What are some things you've done in the past that's helped you learn about your medical, almost asking the caregiver as well, like what has helped you to take care of them? Especially for our cancer caregivers, they're under a lot of stress. They're under a lot of duress at times. They feel like they have to always be the one in control. Like they have to make sure that they're coming to their family member's appointment really ready to receive this information. And sometimes they're not ready as well. So one thing I think is important, and if you don't have this in your institution, we are very fortunate at Memorial. We do offer a lot of support services for our caregivers. So giving them resources about how to reduce their stress, support groups for themselves as caregivers, different elements that we can give them so they can help take care of themselves, so they can take care of their family member or their, the person that they're caring for.
Yeah, I think you're just spot on with that in the caregivers. And, with so many patients getting outpatient treatment and things like that, it's so important that we, as the staff, know who it is that's going to be at home with that patient, and making sure that they have all of the support from us as well that's needed when we're not there to help them out.
Yeah, it makes me also think of us as ourselves as caregivers, right? So we all know that nurses, we take care of so many other people, and we rarely take care of ourselves. So it's almost like we have to take care of ourselves to re-energize ourselves, to really make sure that we're having the self-care so we can give that care to patients and also their family members.
Good point. So, what are some strategies for follow-up assessments?
I think for follow-up assessments, it's like the cornerstones of the teach back will really help with that, because it is really asking these like open-ended questions in your own words. That really helps with that. And when you really, I know we don't have the longest time to talk, but I think when you look at some of those resources I shared earlier, they really dive into this part of like the initial teaching session, the follow-up teaching, and then aftercare. So I think one thing that's important with follow-up is to really make sure like that repetitiveness. So for instance, if we're giving chemotherapy for many sessions of chemo, right? Or many cycles, you may have talked about something in the beginning that the patient's not going to experience for a couple of weeks, or maybe a month or two. So really bringing those back and saying like, we talked about this in the past. Like, what do you remember about talking about this? Or when you're doing your overall assessment of patients and they're coming back to clinic and, they disclose to you, oh, I was really nauseous this week. Okay, what did you do? How did you help treat that nausea? And sometimes patients will say, oh, I didn't really do anything. I didn't really take my med because I didn't really want to. I felt like if I took the med, it would make me worse off. So really like just going back to those elements and reinforcing that teaching. So I think that's really helpful to really like do a reassessment. I think the other thing too, we're in this realm now of patient reported outcomes. And I don't know if some of the people that are listening to maybe use those in their institutions, but we've enacted some ways where patients will fill out almost like a daily tracker of like some of their symptoms. And then that way the nurses can almost review this and say, this patient's been feeling nauseous continuously last couple of days. Let me give them a call and reinforce this is some steps that you can take. So I think as healthcare keeps on becoming more telehealth, more digital, and more about patient reported outcomes, we can utilize that as a tool as well as reassessments.
So, these last 2 years have been hard.
Yeah,
How
for sure.
has how has the pandemic affected the nurse's ability to deliver patient education assessments?
Yeah, I think that there's always an advantage of meeting someone face to face, right? And seeing their body language and seeing how they do. So I think it's important when we're doing education and talking about these things to really try to use video so you can see the patient and you can see their caregivers. It's really been challenging at times when patients are, maybe you're doing Foley catheter care, right? And it's much easier to explain to someone almost when you're doing the teaching to like a demonstration. I'm going to show you how to do it, repeat what's going on. So that can be difficult. So, developing videos that patients can watch or looking at some resources that they can do. And I think for nurses, like we're advocates for our patients, right? So I think it's important for us, if we see a resource is needed, that we speak up. Because for the nurses that are taking care of the patients, at the bedside, at the chair side, really with face to face, hand in hand with them, they know what is needed for the patient. So if there's something that is not available, so say you have a patient that had a colostomy, and you as a nurse are trying to teach them about colostomy care pre or post, and realizing it would be really helpful for us to have a video on this, or that would be really something that would really maybe change the way we can help the patient. Speak up to your nurse managers, your patient ed department, your nursing ed department, so those things can be developed in your certain areas. I think a positive about the COVID pandemic, one positive is that I think education has shifted in a way where when I was a nurse leader, nurse manager in this previous role, that was one thing that came up with a lot of the nurses. They said, it seems like I'm better educating my patients in certain ways because now I don't feel like I'm rushing to do it in the moment, face to face. I could see them in clinic and then they can go home and I can schedule to call them, the next day or maybe later that week when they maybe are in a better space to receive that education. And maybe I can be more thoughtful in the way I do that. So I think that's definitely been a positive, a silver lining within the pandemic, that not everything has to be done face to face.
Yeah. We as nurses, although I think we have always been innovative in the way we care for and teach our patients and things like that, but I think this has almost highlighted that ability that we have to be innovative in how we are figuring out how to care for our patients and teach our patients and family members through this. So I agree with you. I think that has been part of all of that. So, Beau, I just want to, first of all, thank you because this has been just delightful to talk to you about patient education and how we can really try to do a even better job with our patients and figuring that out and assessing them. And as we finish up, I have a few questions that I just want to ask you in a quick fire manner before we finish today. So the first one is, what are common misconceptions about pre and post education assessment?
I think a common misconception is that if you ask a patient, do you understand? And they say yes, you're assuming that they know what you're talking about. So, a lot of times you'll say to a patient, oh, did you understand what I said? And they say, yep. And then that's the end of the conversation. So just don't assume things about patients. Like really make sure you're getting them to tell you it back so you really know that they understood what's going on.
Next, what's something about pre and post patient education assessments that's not often discussed, but you wish people knew more about?
There's definitely two things I wanted to say. There's a lot of information that's free out there from the CDC, from the AHRQ website. There's a lot out there that people can really have some tools that they can take home. And I think also just the theme that I've been talking about a lot with our discussion is just not assuming about patients and not assuming about anyone. So I remember taking care of a physician one time that was a cardiologist, and he was getting pretty high dose chemotherapy. And when I started as an outpatient nurse, I was like, oh, he knows about antiemetics. He knows what pre-meds are. He knows these things. And I really glanced over that, even though it was a very important piece of his treatment, really glanced over it. And the patient, I called him a few days later and he was, extremely nauseous, and realizing that he wasn't really explained what the anti-nausea medicine was for and how to take it and what it meant. So just really not assuming where people are coming from and really teaching people at that basic level. And then if they want more information, they will ask. So patients that really want more and more and more information, they will seek it out and they will ask you and they'll have those conversations. But just don't assume things about patients. Don't assume people can read. Don't assume people can write. Don't assume if someone speaks Spanish that they can read Spanish. Just a lot of those things that we just have to make sure and check ourselves when we're taking care of patients and their caregivers.
What additional training or education do oncology nurses need to deliver pre and post patient education assessments?
Yeah, so I gave those examples from before, but I'm not sure if people know about this, but there is an organization called the Cancer Patient Education Network, CPIN. They're an organization that really focuses on educating very specific patient education related to cancer. They offer a lot of different trainings there. They offer a lot of different resources, especially when delivering bad news, when you have to educate people about, maybe not the best times. So that's something that I think can really help. And then I think, looking to ONS and like, what are the resources there and what are some, there's lots of articles written about these things that are within the ONS journals that we really should be reviewing and really sharing with our colleagues. So if you see something or if you learn something, like sharing it, because I think the worst thing we could do, you get all this knowledge for yourself, but then it goes nowhere. So just make sure you're that voice to really advocate for the patients and the caregivers.
And then last, and you've already mentioned a few, but are there any additional resources for patients and providers who want to learn more?
I think other than what I've discussed already, I think one thing that I'm glad you brought this up is just like, you may have a resource within your institution that you don't know about, especially if you work at a larger institution. There are many times where people will reach out to us and say, we need a resource or need something on this, and it's already there. So really looking within your internal hospital, your internal web, whatever resource you have, just really go around your hospital website and really look to see what is available for patients. Because oftentimes you will find things that you didn't know existed. Because, we all work in silos, we're all working in different areas, and we sometimes forget to communicate with each other. That would probably be one of the biggest takeaways that I would take away is really look to see what you have in your local area, in your local hospital, because you might find what you're looking for there.
Great. Again, Beau, thank you so much for your passion for patient education and just the wealth of knowledge you've shared with us for our listeners. I think that they are going to be able to really glean a lot from our talk today and have a lot of information to take back to use with their patients and to also share with their colleagues. So I really appreciate your time. Do you have any final comments for us?
No, I just wanted to say thank you for this opportunity. It was really great to have a discussion about this, and hopefully this will help get that inquiry for somebody else to really go on to the next steps to really help our patients, caregivers, and our fellow nurses.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.